Gaining freedom from health debt is really what this podcast and greatmed.org is all about, putting power in your hands to improve your God-given ability to be healthy. Many people with preventable disease want to make lifestyle changes. They want to improve or reverse disease, but they don't know how. Walk, Don't Run to the Doctor is the resource hub that is a cure for a common confusion about healthy living. Hello and welcome back to Walk, Don't Run to the Doctor. Thanks for joining me. Today we're going to be talking about statins, drug side effects, drug benefits, and the whole area of awkward medical uncertainty. The idea being that there's a real reluctance on the part of the medical profession and experts in general, in many cases, to really dwell upon what is not known. And the importance of this to you as a patient or to you as a prescriber is that for any given individual, we can't be certain of the benefit versus risk for that given individual. Therefore, we have to lay out the information for the patient, let them know what are the pros and what are the cons, what are the alternatives, and that way they can make their own decision based on their own worldview, because ultimately, this actually doesn't necessarily come down to science because our science isn't good enough. And so first of all, remembering just to step back in terms of the question of science and medical facts. When medical facts are presented to you, find out whether they're really facts or just opinion. That can often be determined simply by asking somebody who's giving you these facts to give you an article about them, or maybe a case series from their own experience, something like that. And that allows you to really see who's just blabbing and who's really got the facts. Then you look at those facts and you say, do they apply to a patient like me? So for example, if I'm a 65-year-old thin, regular exerciser, eats superb food made at home, avoids refined carbohydrates, drinks a small amount of alcohol, doesn't smoke, then the data for cholesterol-lowering drugs is going to be dramatically different, regardless of my cholesterol level pretty much, is going to be dramatically different as to whether it applies to me than if I was a sedentary, smoking, chubby, fast food eating person. And so really knowing who you are with respect to the data that you're looking at. Does the data that you're looking at apply to somebody like you? Thirdly, are there multiple lines of evidence supporting the particular approach that is being proposed? Because if there's not multiple lines of evidence, remember that most medical literature isn't great. So it's all flawed. And the reason is that we're dealing with flawed human beings. So it's really hard to get super good data. They don't behave themselves like rats and lawyers do. Next, you want to ask yourself, what is the opposing evidence? So for every argument for something, there's probably an argument against that same thing. So know what those 2 points are. And finally, realize that you can work with your doctor to answer these questions. This is not too complicated for you. Because remember, your doctor has to know about hundreds and thousands of diseases probably, or variations on diseases. You only have to know about a few. You can do this. So being a patient is hard work. You should think, you should analyze, you should ask questions of multiple sources, including opposing views, as I said, before you engage in a medical intervention, unless it's a true urgency or emergency. And you can do this. The whole idea is you have to take responsibility for the decisions you make. And if some doctor puts you on a medication that does you harm and you haven't done your homework, then that's on you. It's also partly on your doctor, of course. And to get there, sometimes you need to learn a little cynicism. John Ioannidis in 2005 wrote a famous paper called Why Most Published Research Findings Are False. And that's worth reading. It's a biomedical paper from 2005. And H.L. Mencken, a long time ago, probably 100 years ago, said, for every complex problem, there is an answer that's clear, simple, and wrong. And so if you're somebody who's being told, hey, you have high cholesterol, you need a statin, that sounds like somebody who's taking a complex problem, high cholesterol, and heart disease risk, and is pretending that there's a clear and simple answer to it, statin therapy. So watch out for oversimplified solutions if you are the recipient of them. How does all this apply to statins in particular? So if we look at patients who are at increased risk of heart disease, who don't necessarily pay a lot of attention to diet and exercise and waste management, statins probably do reduce the risk of heart disease and stroke and death. And in patients who haven't already had a heart attack, then the absolute risk reduction is probably about 1 event per 100 patients treated for about 5 years. So that's a 25% relative risk reduction or a 1% absolute risk reduction. And this is from the CCT collaboration from 2012 and others. So that's a pretty generalized piece of data that's largely supported in literature. And so if you're listening to this and you really don't want to make healthy choices, then maybe a 1% reduction in risk or a 25% relative reduction in risk, being 1 in 100, having a 1 in 100 reduced risk of an event over 5 years, maybe that sounds good to you. And taking a medication, it's easy to do, especially if you're not getting any side effects, and that might work for you. But where it gets a lot more complicated is that in people who have a good diet, good waste management, in other words, they're not chubby, who are physically active, who drink a small amount of alcohol, and who don't smoke, are already at dramatically lower risk, 50, 70, 80% lower risk of heart disease and stroke. So that the statin benefit in that group is presumably much less and may not even be statistically significant. And that is even if they actually have a high statistical risk from the standard guidelines we use, which can be misleading based on, say, cholesterol. And so, the kind of data that shows that these people who take good care of themselves are at dramatically lower risk of heart attack and stroke anyway are things like the Nurses' Health Study, the Lyon Heart Trial we'll touch on again in a little bit. And more recently, there's a really interesting paper called China Heart in the American Journal of Preventive Medicine in 2024. And so with that group, you're saying, wow, they already have a significantly lower risk. Do statins add anything to that risk? Do they lower the risk any further? Because you can only lower the risk so far. And so we've talked about a couple of statistical terms, and so we'll just touch on what those mean, because for anybody who's interested in making good healthcare choices, then there's 3 statistical terms that you really should know. Even if you hated statistics, you should still know about these 3. And once again, if you start playing around with them, you'll get the hang of it pretty quickly. The first one that we use is called number needed to treat, which is kind of the same as saying absolute risk reduction. And so what that says, for example, to use statin therapy, if I treat 100 people who have not already had a heart attack for 5 years with a statin, and I have a control group of another 100 people given a placebo for 5 years, and let's say there's 4 events or heart attacks or strokes, death in the placebo group and only 3 in the statin treatment group, that means we've prevented 1 event out of 100 people over 5 years of treatment. And that's called an absolute risk reduction of 1%, or a number needed to treat of 100. In other words, I had to treat 100 patients to prevent 1 event, an absolute risk reduction of 1%. Now, if we look at the same statistic a different way and say, I've reduced 1 event out of 4 that otherwise would have happened. In other words, the placebo group had 4 events, the statin group had 3 events, such as heart attack and stroke, death, so that kind of thing. And therefore, I've reduced the number of events by 1 out of 4, or a 25% risk reduction. So normally you'll see this relative risk reduction number used because it's a much more impressive number. 25% sounds a lot better than 1%, doesn't it? And yet we're actually using exactly the same data. And this is an old concept, of course, that figures don't lie, but liars figure. So if I'm trying to sell something, I'm going to give you the 25% number. If I'm going to try to inform you as to how much benefit there is for you, I'm going to use the 1% number. But in a little bit, we're going to talk about how if you take good care of yourself, even that 1% number may not apply. In contrast, the previous example I was using was in people who had not already had a heart attack. Now, if I'm looking at people who have had a heart attack or a stroke, then statin drugs have a much more impressive record. So in that, you could even argue that maybe for every 10 people treated with a statin for 5 years, if they've already had a heart attack, we might prevent 1 event, and that might include death. And that's a much more impressive result, and that's really worth knowing about. So if somebody says, statins only help 1%, well, that means that they're using data from people who've not already had a heart attack. And if you've already had a heart attack, that data doesn't apply to you. So, and the number I just mentioned is from the Cholesterol Treatment Trialists collaboration. Now, if you're a very healthy person who've not had a cardiac event, then the benefit from the statin may be, in contrast to what I just mentioned, maybe only 1 in 500 people getting a benefit, which most of us would consider not appropriate to take a pill for that. So if you're healthy and you haven't had a heart attack, the degree of benefit from statins is dramatically different than if you're not healthy and you have had a heart attack. And in a little bit, we're going to be talking about somebody who's very healthy who has had a heart attack and whether statins help them. And at this point, you may be saying, oh, my doctor told me to take a statin and he was giving me completely different numbers. And this is worth paying attention to because there's hundreds of studies, maybe thousands. There's at least dozens, if not hundreds, of meta-analysis in this area. And so there will be different numbers. And so look at where the numbers are coming from. A couple of, the cholesterol treatment collaboration is one that we already mentioned. The Cochrane collaboration is another good one. And so if you're trying to make decisions for yourself, then getting comfortable with search engines such as Google Scholar or even AI is worth doing, but it's going to take you time. You're going to have to frame questions really carefully so that you get the answers you're looking for. You're going to have to spend hours at it. But in so doing, you're going to make much, much better health decisions. And hopefully you have a primary care doctor who cares about this stuff as well and is willing to go over everything with you. We'll talk more about that in a little bit. So I've just given you some pretty good numbers on why people with risk factors, especially a previous heart attack, for a statin might get real benefit, including reduction in death. And so you might be asking at this point, well, why wouldn't everybody take a statin? Well, there's a bunch of reasons. One, potential harms need to be taken into account. Most people who take a statin don't get obvious side effects, but there's 3 areas of statin harm that are worth knowing about, maybe 4 areas. One is muscle injury, which is common. Second is diabetes risk, which is also probably pretty common. Third is cognitive function, which is, we'll touch on whether that's common or not. And fourthly is this concept of polypharmacy. How many drugs do you want to take, and when do multiple drugs no longer have benefit for you because of potential drug-drug interactions? And so these harms that we're talking about need to be balanced against potential benefit. So if we look at muscles and diabetes risk and statins, then about 1 in 10 statin users, probably somewhere in that region, will probably have muscle pain and weakness. And that can be quite disturbing to a lot of people. So if that's happening to you, don't be embarrassed by it. It's not you being weak or needing to work out more. It's probably just a straight old statin toxicity. And we, if we're going to have somebody on a statin drug in our practice, then what we do then is either lower the dose or change the interval. For example, I've got some patients who are on a statin once a week, and they actually do really, really well and have fabulous biochemical results and seemingly good medical results as well. Do I have any data for that? Not at all. Does it mean I'm not poisoning my patient? Yep. The next thing to think about is diabetes risk. So diabetes risk is probably increased maybe by as much as 20%, probably mostly in people with prediabetes, and it also accelerates progression of diabetes. So what's the number? Probably about 1 in every 200 patients who take statins over 5 years, maybe more than that. And so there's various data out there, but the 20% relative risk reduction number is a commonly cited one and probably about right. Just dwelling on this really briefly, remember that diabetes is a big deal. The most common cause of dialysis in the country, stroke, heart attack, kidney failure, liver failure, dementia, probably a doubling or a tripling of risk of cancer. Diabetes is not a diagnosis to be minimized. And in actual fact, I would argue that we would do more good for our society if we emphasize diabetes and prediabetes rather than cholesterol. I think statistically we'd be way ahead. But obviously it's not an either or thing. We can actually emphasize both. So now let's get on to the next issue, which actually might be related to diabetes, and that is the issue of cognitive dysfunction with statins. So in background, the large randomized controlled trials for statins that had thousands of patients in them have not seen an increase in cognitive dysfunction. But in reality, in practice, I've been in practice for decades, and we do see patients regularly who get cognitive dysfunction from statins, and when they stop the statin, it comes back. And this happens over and over and over again. So we're sure that it's a real phenomena. And the FDA in 2012 did add a safety label for memory loss, confusion, and cognitive impairment for statins. So it's been observed, it's been it's real, but we have very poor data on this. The individual observational studies have shown a lot of this. The FDA bulletin, of course, should concern us. And probably the best data I know of is the 19% increased risk of Alzheimer's disease that was observed in the UK Biobank study, which is in the Journal of Preventive Alzheimer's Disease in 2025. And you could go on and on about the potential why this is the case, but remembering that the statin drugs, the HMG-CoAs inhibitors, these do suppress a mitochondrial enzyme. So it shouldn't surprise us that it has mitochondrial effects in various ways we've already mentioned in the muscles. But glucose metabolism can then affect cognitive dysfunction. So it's very plausible. So we've talked about muscle injury, we've talked about diabetes risk, we've talked about cognitive dysfunction risk, and finally, this issue of polypharmacy that I don't think any of us should take lightly. And that is, every time you add another drug to a given individual, you really have no idea of how the previous drugs and the new drug are going to act in that person. We are all flying blind when it comes to polypharmacy because we simply don't have the data for every type of person to tell us what combinations are the best. And so the rule there is to try to keep the number of drugs that you're on to a minimum. Do I really need this? And we'll talk about who might really need a statin and who might not. So before we get onto that in a way, let's look at lifestyle and heart disease risk. So in observational studies, let me just make one comment about lifestyle medicine literature. Lifestyle medicine literature is even worse in terms of quality than pharmaceutical literature. And once again, the reason is it's really hard to measure who's eating what, how much they're eating of it, how chubby they really are, because there's different ways of measuring weight. How much alcohol are they drinking? Are they really smoking or aren't they? Are they eating red meat that they've cooked, a pot roast that they've cooked with vegetables at home, or is their red meat hamburger from a fast food joint? These are all variables that are really hard for the investigators to take into account. So if we look overall at observational studies, and probably a good one to cite here would be the Nurses' Health Study and the Health Professionals Follow-Up Study. They cite about anywhere from a 50 to 80% lower relative risk of heart disease and stroke in those who, listen carefully, exercise every day, eat a good omnivorous diet, meaning all traditional foods, but primarily whole foods, minimizing in particular refined carbohydrates like sugars and white flour, who aren't chubby, so they have a waist that goes in and not out, who drink a small amount of alcohol. Small amounts of alcohol are protective for longevity and for heart disease and stroke, and who don't smoke. So what we don't have is any study using statins in this group to say if there's any additional benefit. So if you're one of the people who are already doing this, you've got adequate basis. You already know you're at dramatically lower risk, and you don't know if statins are going to improve that risk or not. So it's a fair question, and you might decide to go on a statin because you have high cholesterol, or you might decide not to go on a statin despite your high cholesterol. And both decisions would be actually reasonable. We have a bit better data for lifestyle medicine in secondary prevention. So the previous group I was telling you about were lifestyle medicine in people who largely had not already had a heart attack. This group I'm telling you about, I'm going to use the Leo Heart Trial for my example. This studied the Mediterranean diet in a group of people who had already had a heart attack within 6 months, and they were followed for 4 years. And half of them were told to go on a whole food Mediterranean-style diet, largely cooked at home, which might be an important factor. The control group were recommended to follow what the American Heart Association was recommending at the time. So these were two good diets compared to each other. This wasn't a really good diet, Mediterranean-style diet, compared to a really bad diet. These were two pretty good diets. And yet, the Mediterranean-style group in this study, after 4 years, had a relative risk reduction of 59% for death. So the number needed to treat with the Mediterranean diet to prevent one death in this group that had already had a heart attack was 15, or a 59% relative risk reduction. The relative risk reduction for another heart attack, so the previous data was for death, for reducing heart attack, the risk reduction was 71%, or a number needed to treat of 10. So every 10 people that we put on the Mediterranean diet who had already had a heart attack, then we had one fewer heart attack after 4 years. And to prevent one cancer, with the number need to treat was 23. The cancer reduction data was equally impressive. So, you might be saying, even though I've had a heart attack, maybe if I ate a really good diet and exercised and drank a small amount of alcohol and kept my weight down and exercised every day, maybe more than once a day, would a statin have any additional benefit for me? And that's a very reasonable question to ask, and it's not one anybody can answer, because these data from studies such as Leo Heart Study are pretty impressive. And they actually look like they're at least as good, if not better, than the data from statin trials. And so this is that area where it's, to circle back, where we're talking about the uncertainty. We don't know what the right thing to do is. And it's obviously easy if you're having bad side effects from statin therapy. It's pretty easy to say, hey, I'm just going to do the diet and exercise thing, and that would not be unreasonable. If you don't have any side effects from statins, you might be somebody who says, you know what, I don't mind taking another medication. It might have additional benefit, and you might be right. So whatever you do, start with doing those things that are the most important for your health. And we would argue an omnivorous Mediterranean diet, mostly cooked at home, and avoiding refined carbohydrates like sugars, juices, sweet drinks, and basically foods made with white flour. Moderate alcohol, meaning probably a drink a day or less. Vigorous exercise every day. And in our practice, we say if you're not getting short of breath, you're not exercising. Having an appropriate waistline. If you're chubby, kind of all bets are off. And in regard to this, we'd also say if you've got prediabetes, reverse it. Double down on all of your good lifestyle measures so you're no longer prediabetic. Because prediabetes, we would submit, is probably a greater risk factor for almost everything bad that can happen to your health than high cholesterol is. And we'd strongly recommend you consider looking at our book, Good Food, Great Medicine, in its 4th edition, for help with all these decisions. And if you do pursue prudent lifestyle choices vigorously, the question of whether to take a statin or not is much less important, because the benefits of good lifestyle choices extend well beyond your risk of heart disease and stroke. Their cancer risk, their diabetes avoidance, their mood, their well-being, their muscle mass, their dementia risk, all of these things that mean that you live better in 5 and 10 and 15 and 20 years from where you are now. Now, if you're somebody who thinks about these data and maybe read some of the papers that we've cited, and then you talk to your doctor, and your doctor says, what, you're not taking a statin? That's insane. That's bad behavior. In fact, I might fire you. I have had patients who've told me their doctor fired them for not taking a statin. Then simply calmly sit down with your doctor and go over the degree of benefit and potential harm with statins based on studies and people like you. Take into account your lifestyle choices. Make sure your doctor is thinking about what your case is, not an algorithm on their computer. It might be that your doctor is right. And so, for example, if I'm repeating myself a little bit, but if I'm sitting down with somebody who's not taking care of themselves, who has high cholesterol, especially if they've already had a cardiac event, I'm absolutely going to recommend a statin, because it's going to reduce their risk beyond any reasonable doubt, and it's worth a small degree of harm. But if I'm taking care of somebody who's really taking great care of themselves, and they don't want to take a statin, I say, that's fine with me, because I can't demonstrate that the statin in somebody like you is going to have any additional benefit. So before you take any medication, under any conditions, always compare the benefits and harms in people like you, if that information is available. If that information isn't available, then that should be something you take into account as well. That means everybody's guessing. And you don't want to be the subject of guesswork, in my opinion. So, the more risk you have, such as high cholesterol, a prior heart attack or stroke, then probably the greater benefit there is in taking a statin. So, if you come away from this thinking I'm just an anti-statin guy, then you're wrong. I'm also not a pro-statin guy, except in the minority of patients for whom they clearly help. As with all medications, this is my summary statement. Statins can have negative as well as positive effects, including cognitive function, and so talk this over with your doctor. And whether or not you take a cholesterol medication, remember that your diet choices, waistline, and activity levels are far more important than statin choices, not just for heart disease and stroke, but also cancer and diabetes and dementia. Thank you, and thank you for listening to Walk, Don't Run to the Doctor.